Endocrinology Minutes with Cyan. Hyperthyroid and Graves' disease. Hyperthyroidism has a prevalence of 1 to 2% in women and 0.1 to 0.2% in men. In this chapter, we will touch on the three topics: thyrotoxicosis and its clinical manifestations, Graves' disease and its treatment, and finally, thyroid storm, accelerated hyperthyroidism. Clinical manifestations of the thyrotoxicosis. Cardiovascular system. Increased circulatory demands that result from hypermetabolism and the need to dissipate the excess heat produced is common. Tachycardia is virtually always present and is due to a combination of increased sympathetic and decreased vagal tone. Widening of the pulse pressure, palpitation, atrial fibrillation is also common. Nervous system. There may be a fine tremor of the hands, tongue, or lightly closed eyelids. Muscles. Graves' disease occurs in about 3 to 5% of patients with myasthenia gravis. Eyes. Graves' orbitopathy mainly includes stare, lit lag, globe lag, ocular manifestations. Respiratory system. Dyspnea is common in severe thyrotoxicosis, alimentary system and nutrients metabolism. The stimulation of metabolism and heat production is reflected in increased appetite and heat intolerance, but only rarely by elevated basal body temperature. Bowel movement is increased, which causes diarrhea and weight loss. Skeletal system. Increased secretion of calcium and phosphorus in urine and stool, with an increase in bone turnover and a net demineralization of bone, and occasionally with pathologic factors. Hypercalcemia may occur in patients with severe thyrotoxicosis. Hematopoietic system. Approximately 3% of the patients with Graves' disease have pernicious anemia. Splenic enlargement occurs in about 10% of the patients, and thymic enlargement is common in Graves' disease. Reproductive function. In some patients, menstrual cycles are predominantly and ovulatory with oligomenorrhea, but in most, ovulation occurs as indicated by a secretory endometrium. Masked or apathetic thyrotoxicosis. The symptoms and signs of thyrotoxicosis are more readily recognized in the younger than in the older patients. The term masked or the apathetic thyrotoxicosis is used to describe a syndrome sometimes seen in the elderly, which may present as congestive heart failure with arrhythmia or as unexplained weight loss without an increased appetite and other typical symptoms and signs for the younger patients. Graves' disease. Due to length limitations, we will focus on the Graves' disease, omitting other major causes of hyperthyroidism including the toxic multinodular goiter, excessive thyrotropin secretion, and subacute thyroiditis. Graves' disease is the dominating cause of hyperthyroidism, representing about 80% of all causes of thyrotoxicosis. It is a syndrome consists of the three elements. The first, symptoms and signs of thyrotoxicosis. The second, swelling of the thyroid gland. And the third, protruding eyes. The nature of the disease is the hyperthyroidism caused by thyroid-stimulating autoantibodies. The presentation of the thyroid, eye, and skin signs is referred to as the Graves triad. Risk factors include genetic and epigenetic susceptibility, stress. Stress induces an overall state of immune suppression by nonspecific mechanisms. Gender. Graves' disease is 4 to 5 times more common in women than in men, and it becomes more prevalent after puberty. However, there is no fall in the incidence of Graves' disease after menopause. Androgens may actually suppress autoimmune thyroiditis. Pregnancy. Hyperthyroidism induces an increased risk of pregnancy loss and established pregnancy complications. However, pregnancy is a time of immunosuppression, so the disease tends to improve as pregnancy progresses. Rebound from this immunosuppression after delivery may contribute to the development of postpartum thyroid disease. Drugs. Iodine and iodine-containing drugs, such as amiodarone and iodine-containing contrast media, may precipitate Graves' disease or its recurrence. Irradiation. There is no evidence that radiation exposure itself is a risk factor for Graves' disease. Although Graves' disease is well known to be precipitated in some patients treated with radioactive iodine for multinodular goiter, radioactive iodine treatment leads in the majority of patients to a steep increase in thyroid-stimulating hormone receptor antibody that returns to pretreatment level after a year. Treatment. Existing therapies for both the thyrotoxic and ophthalmic manifestations or have significant side effects. Anti-thyroid agents. The major agents for treating thyrotoxicosis are drugs of the thyronamide class, most commonly methimazole, carbimazole, and propylthiouracil, also called PTU. PTU is no longer recommended as first-line therapy because of its rare but occasionally severe hepatic toxicity. PTU may be useful in treating severe hypothyroidism because of its capacity to block conversion of the T4 to T3 by the type 1 deiodinase in liver, kidney, and Graves' thyroid. Mild side effects occur in up to 20% of patients and include skin reactions, arthralgias, gastrointestinal symptoms, an abnormal sense of taste, and occasional sialadenitis. Of the most serious side effects, the one most talked about is agranulocytosis, which occurs in 0.1 to 0.3% of the patients, generally within the first few weeks or months of treatment. Because of the high frequency of lymphopenia in hyperthyroidism itself, a complete blood cell count with differential is recommended before antithyroid drug therapy is started. If the absolute neutrophil count falls below 1,500 cells per microliter, the drug should be withdrawn and the patients treated with antibiotics as appropriate. Predicting the response to drug withdrawal. Up to 50% of patients may go into remission after a course of antithyroid drugs. Antithyroid drug therapy should generally be continued for about 12 to 18 months and then withdrawn if the serum thyroid-stimulating hormone returns to normal. Iodide transport inhibitors. Both thiocyanate and perchlorate inhibit thyroid iodide transport and have been used to treat hyperthyroidism. Perchlorate has been used to treat patients with amiodarone-induced hyperthyroidism. Iodine and iodine-containing agents. The major action of iodine is to inhibit hormone release. It is now rarely used as a sole therapy. Other antithyroid agents include cholecystographic agents like cholestyramine, lithium, dexamethasone, and beta-blocking agents like propranolol. Surgery. Surgery was the original treatment for Graves' disease before the advent of radioiodine and the thionamide drugs. Because of the occasional recurrence of hyperthyroidism after the popular technique of subtotal thyroidectomy, the surgical procedure of choice for the treatment of Graves' disease has become a near-total thyroidectomy. Complications such as permanent hypoparathyroidism and damage to the recurrent laryngeal nerve is quite low. Other complications include bleeding into the operative site, asphyxia, and dysphonia. Preparation for surgery. Iodide 2 to 3 drops twice a day should be initiated at least 7 to 10 days before surgery to decrease thyroid blood flow and vascularity and hence intraoperative blood loss during the thyroidectomy. Radioiodine therapy. As for preparations, anti-thyroid drugs are withdrawn 3 to 7 days before treatment. If needed, they can then be reintroduced 7 days after treatment. Radioactive iodine should not be administered for at least 8 weeks after cessation of lactation because it is concentrated in breast milk. Women planning to become pregnant are advised to wait for an arbitrary period for at least 6 months after radioactive iodine therapy to allow for resolution of any transient effects of gonadal radiation and stabilization of thyroid function. The most common complications of radioiodine therapy are thyroid cancer from low-level radiation exposure, hypothyroidism, and radiation thyroiditis. Thyroid storm, or so-called accelerated hyperthyroidism, is an extreme accentuation of thyrotoxicosis. Presentation: Thyroid storm is usually of abrupt onset and occurs in patients in whom pre-existing thyroid toxicosis has been treated incompletely. The condition is usually precipitated by infection, trauma, surgical emergencies, or operations, and less commonly by radiation thyroiditis, diabetic ketoacidosis, toxemia of pregnancy, or parturition. The clinical picture is one of the most severe hypermetabolism. Fever, sweating, tachycardia, and arrhythmias may be accompanied by pulmonary edema or congestive heart failure. As the disorder progresses, apathy, stupor, and coma may supervene and hypotension can develop. The condition may be fatal, so emergency treatment should not wait laboratory confirmation. Treatments of thyroid storm. The patients thought to have thyroid storm should be monitored in a medical intensive care unit during the initial phases of therapy. PTU is administered before iodine. Large doses of dexamethasone are used. If beta-adrenergic blocking agents are contraindicated, a calcium channel blocker like diltiazem may be used to slow the heart rate. Salicylates should be avoided because they compete with T3 and T4 for binding to thyroxine-binding globulin and transthyretin, and therefore increases the free home levels. High doses of salicylates also increase the metabolic rate. Thanks for watching. If you enjoyed this video, just replay it. If you have any questions or suggestions, feel free to contact me through email. If there is the next episode, see you then!